over to Tina to kick us off. Tina, thank you for joining us, even though you're covered in, 28 inches of snow over there?
At least. Hello, everyone. My name is Tina Laprade. You'll see it pop up as Valentina Laprade, but everyone calls me Tina. And I have been very blessed with being able to have a few federal projects that I oversee. And I'm going to go over some of the results of a 5-year project that we finished up in 2012, and then talk a little bit about our current one, and focused on, obviously, client engagement and retention. So this was a 5-year project that was part of the RPG grant, and it was focused on a dosage-specific design based on client levels of participation. So, and basically the way we defined that was somewhat based out of the, not somewhat, it was based out of the literature, where we decided that 76% or higher participation by a client in all of the activities would be designated as a highly dosage level, highly involved. 75 to 51% would be moderately involved. Then 50 to 26% would be slightly involved. And then anything under 25% would be designated as our control group, which was a did not engage group. So that's how we defined our levels of involvement for clients. Obviously, clients self-selected their level of engagement with our program. This was an intensive home-based, still is, an intensive home-based model. And we based a lot of our practice on our strengths-based practice, and it was focused on being trauma-informed as we worked with substance-affected families involved with the child welfare system. And basically what we found over the 5 years, that greater levels of involvement equaled permanency and stability for all children and families that were involved. Some at the clinically significant level, typically our highly involved group. We saw increased safety for children, improved child well-being. We saw higher rates of substance abuse treatment completion and improved adult mental health. Mostly, we saw some moderate gains amongst the moderately involved group, and we saw the highly involved group making, obviously, the most important and highest strides. But we even saw, particularly around child mental health and rates of substance abuse completion, even amongst our slightly involved folks, we actually saw some gains as well. Improved parenting abilities and parent-child bonding, stronger family relationships, and a significant decrease in prenatal substance exposure, which our nurses were incredibly thrilled with, because we went in the beginning of our interactions back in 2007 with about a 78% not prenatally exposed rate, to after the 5-year project, when we were looking at the importance of engagement and involvement with clients, we actually are at 91% of children not being prenatally exposed, not tox positive at birth. So the nurses in our program are very, very impressed with that number, and they worked really hard with our moms, particularly around prenatal care, when they came into the program pregnant or got pregnant while they were in our program. Our team consisted of a master's level clinician, a nurse, and a bachelor's level parent educator. So the next, it didn't go to the next slide, hold on. So I was asked today to talk about some of the things we found during those 5 years, and we continue to find, around engaging families. And what we found was basically a focus on strengths while balancing child safety. About half of our population during this time was in the home. Our children were in the home. And then about half of our referrals were actually children that were in foster care and out of the home. So there was always this balance for our workers. Hello? A focus on for our workers on really balancing what strengths we were seeing with the parents and the children, but also making sure that people were safe. We always would talk about being very interested in the family's culture and history. We have a focus for this program, but also within our organization, a focus on representing our client population in our staffing patterns. So we have a number of folks on the team that are bilingual and bicultural. Actually, we have one person who's trilingual. We always had to continually remind ourselves, as far as our lessons learned, that we have to remember that even good parents have bad days, that we all get stressed out as parents, and that even parents who are struggling can be make very significant gains, particularly around developmentally appropriate expectations, but that there are given days where they wouldn't do well, and that didn't encompass the whole of who they were. Engage the family in identifying all natural possible supports. This was something that we actually learned from our high fidelity RAP people in a different program I oversee, is that we got very good, this team, at looking at who else the parents could bring in, even if it was just for a ride or for more emotional support, even if they were out of state or out of county. We really did look at making sure that we shored up those supports as much as possible, because our program would go away and we knew that. And so it's really important for people to continue to make the gains they made and sustain them and maintain them by paying attention to their natural supports or creating them in some instances. We had a strong focus on meeting the concrete needs of families, and I got to say, I'm the person who got to see every single client satisfaction form that came through over the 5 years. And in our analysis, the number one thing that families talked about, well, actually, number one and number two. Number one was their relationship with their worker, came through time and time again. And then the second thing was them being able to have their concrete needs being met. The population we were serving was incredibly poor, typically under $10,000 of income per year. And so concrete needs and helping families figure that out and was something that they identified continually over the 5 years as important. Be empathetic and empowering, be a role model for nurturing, acceptance, and ability to express and regulate affect. This was something in team meetings that we met on a weekly basis and continue to do so. That is really important, particularly when children are being removed. We don't typically sit through a removal. That's our child welfare department. But being able to sit with that, those intense, strong emotions of loss and grief and pain, was something that we had to practice as workers on a continuing basis. And again, families reported, and we saw in our outcomes, as being something very important to continue to engage a family. Believe that change is possible. We say this fairly often, even when we have our bad days as workers. Have reasonable expectations. One of our supervisors says on a consistent basis that change comes in increments, and it is incrementalism at its best. So we always wanted to make sure for parents any change and movement in a positive direction was something to be celebrated. We wanted to make sure that we measured our success concretely. We partnered with our families and really focused on making it's their goal, not our goal, and that's sometimes difficult to balance when you're working with a child welfare involved population because they're mandated to do a lot of things. So a lot of times what they would say to us is, truthfully, what we want is child welfare gone from our lives, and that was a goal we would set. And basically the way that goal could come to fruition is that they actually did all of the tasks on their child welfare plan, and we helped them do that. Be aware of your use of self is something we talked about many times as a worker, and workers paying attention to their use of self. Self-disclosures. We do have people on our team that are in recovery. when to tell that, how to tell that, was an ongoing discussion on a repeated basis. And for anyone in this field, we constantly had to remind ourselves that we had to have a highly developed sense of humor, because we would run into situations, and I'm sure you all do as well, where a situation would come up that we could never predict in many, many years, and we would have to smile and grin and bear with it and have a good sense of humor about it, and also teach our families to have not laugh through life, but actually see the positive and reframe things in a positive light, and humor is a good strategy to do so. Client engagement and retention, what we also found is that a strengths-based approach and philosophy helped us in getting the outcomes we had realized, that we stay individualized with our families and we stay culturally focused. And there are many subcultures, particularly in substance abuse, beyond ethnicity and generalized culture, but there's also beliefs around the differences between an opiate user and a cocaine user, and then you have people who are monogamous with their substance, and then other people who will polysubstance abuse, and there's cultures within that group as well. Having mutually acceptable goals, that we are purposeful and practical in our strategies. We have to do what makes sense, and that's a reframe that we did and said throughout the 5 years and continue to say. We have to make measurable and relevant plans and consistently give progressive feedback to our families, and these are some of the not just strategies, but approaches that we found useful and helpful during our process. So here's some of our outcomes. 72% of our children that were already at home stayed safely in the home. There are times where we actually did have to make the recommendation with the parent that the children have to be removed, and then we actually then worked with those parents to reunify. So 77% of our children were able to be reunified with their parents. 91% of our infants tested negative for illicit substances, actually any substance, at their birth. Amongst the children that were born after mothers came into the program. Children made significant gains in their mental health and behavioral issues. As far as parent outcomes, 63% of our parents successfully completed substance abuse treatment, which is much higher than we expected, truthfully. 66% of our highly involved parents improved in their mental health scores, again, significantly so. 72% of our showed improvements in their parenting abilities. And more involved parents showed particular strengths in parent-child bonding and attachment. We actually saw that at the 0.01 level, which was very exciting for us. Our client's perspective, these are just a few quotes that I gleaned from some of our client satisfaction surveys. So one mother said, we addicts need to be taught more than just staying clean. We need to learn a new way of life for us and our children. And this next quote really speaks to, and most of these quotes speak to, the relationship that was built. She had to see something in me. I didn't understand it. She never condemned me. She never put me down or made me feel worthless. Even when I was at my lowest, she made me feel worthwhile. She said, I have confidence in you. That gives you strength. You need to have it. It helps a lot, especially when you didn't have it yourself. Most of our population, and when we studied this in our early days, about 95% of our population identified significant trauma in their lives amongst our women. And our fathers, we didn't study them as vigorously as we did our moms, but I would say that it's probably on a similar footing. So based on our research, what we then did was apply for the AIA grant, and what we wanted to look at was take parent-child relationships and focus on them even more than we were before, and really focus on the social emotional development and attachment. And so our current study is looking at, and that's a randomized control study, we're looking at parent-child relationships based on a therapeutic intervention process, and we're really looking to support attachment and improve social emotional development and bonding. Hello?
Tina?
Yeah?
Okay.
Okay, sorry. So we are also continuing with our comprehensive, intensive home-based model. We're looking at permanency facilitation. So what we also learned in our 5 years was that visitation is challenging within the child.
It looks like Tina just got booted. Tina, are you back?
Hello?
Yes. Yeah, Tina, you're here. Go ahead.
Sorry. Are we okay?
Yes.
Okay, excellent. Hello, everyone. I'm back, I think. As far as permanency, we looked at visitation, we looked at the research, and what we found in the research is that once in our area on the East Coast, in Providence, Rhode Island at least, visitation is only guaranteed for 2 hours, one time a month for parents, and we found that bonding and attachment are not facilitated, or honestly, it doesn't make a whole lot of sense to us, and the research certainly doesn't bear that out. So what we actually in our program is visitation is a minimum of 2 times per week, and it's focused on building that parent-child bond and attachment, as long, again, as children and parents can be safe. And then the fourth goal we had and continue to have over these past 2 years is a focus on training and consultation for our staff. So that is the end of my presentation around client engagement and retention. I'm going to turn this over to Jennifer, and you can certainly ask me any questions at the end.
Thank you, Tina. Hi, everyone. My name is Jennifer Lewis, and I am a clinical supervisor at the UCSD Mother, Child, and Adolescent HIV program, and we are funded through ACF for a program called Families First. Let's see. Could you advance the slide, please? Thank you. So what I'm hoping to do today is to speak to the engagement and retention and care, and really some best practice strategies for working with our population, which is HIV-positive women who are pregnant and parenting, who have co-occurring mental health and substance abuse disorders. By the time I'm finished, my goal is to have you be able to identify some multi-level approaches that impact engagement and retention and care among high-risk families, and have real tools to implement in your agencies that will positively impact the engagement and retention.
The conference has been unmuted.
Can everybody hear me? Okay. So who are we? We are, again, called Families First, and our goal is to reduce the risk of child abandonment and neglect through the early identification and implementation of an integrated intervention designed to treat substance abuse, mental illness, and HIV-positive parents, and to develop and support their role as active and engaged parents. But basically, we are an outpatient, hospital-based, interdisciplinary team providing social services and mental health in the context of HIV medical care. So on our interdisciplinary team, we have our medical provider, our substance abuse counselor, our mental health clinicians, licensed social workers who are providing DBT and supportive counseling, EMDR. We have a psychiatric nurse practitioner who's doing medication management, and a we have a family counselor who's doing nurturing parenting and PCIT, and we have case management. So probably like most of you, our clients are single parents with histories of extensive CPS involvement, are underemployed, impoverished, marginally housed, many of them at times homeless, lack of resources related to transportation, food insecurity is significant, low health literacy, low education, many of whom have histories of trauma and domestic violence that are significant, and are oftentimes in crisis in terms of daily living. So for those of you who are not familiar with HIV, President Obama released the National HIV Healthcare Strategy about 3 or 4 years ago, in which the strategy really guided our intervention working with HIV-positive individuals. And whereas we used to really focus on prevention, it moved more towards what we call secondary prevention, empowering people to get into care once they know their status, to take medication, to have what we call an undetectable viral load, which is the result of being adherent to your medication. And with that, it would reduce the likelihood of transmission. So if you're not using a condom and you have a low viral load, the chances of transmission to another is unlikely. So our field of HIV has really focused on engagement and retention for those HIV-positive individuals. So for a very long time, I think everybody in our field has been focused on how do we keep people coming back to our organization, how do we keep them actively engaged, how do we keep them connected. So I guess with that, I'd like to unmute everybody and ask you to think about what keeps you coming back to a meeting or a club or a group that you belong to. What are those qualities that keep you going back?
For me, I think it's a friendly environment and some place where I feel welcome and understood.
Yeah, absolutely. I think those environments where you feel like people actually are interested in you, for sure, are going to help you stay engaged. Anybody else?
Accessibility, I would say.
Accessibility, excellent. So being able to actually get in and get out with busy lives, for sure. Anybody want to, Amanda, if you wouldn't mind advancing? And what would deter you from engaging in an activity or a program? So what are those programs that would keep you from either engaging or continuing to go?
Where I don't feel welcome or wanted, or they acknowledge me, my presence.
So if you didn't feel like you were actually having a connection with people, or they were you were a number or not somebody that was important to them, you certainly wouldn't go back. Good. Anybody else?
Depending on the timing, I would need to work out childcare issues.
So a lot of the logistic kind of issues in terms of being able to do it and make sure that you have the resources in order to make it work. Absolutely. Well, I think what I'd like to do is sort of share a little bit about our approach. We have found, we're still in it in terms of the research and looking at our data, but we're seeing some early success. And so when we've talked with our staff about what we feel like we could attribute it to, even from in an early time frame, the feedback has been that it's our actual system. It's the system that we created that seems to have an impact on our outcomes. And so what I'd like to do is sort of talk about that from a multi-level approach, both from the staff, organization, and community in terms of what we've implemented and why we believe it's been successful. So from a community perspective, we believe, probably as all of you do, that it's important to have strong community relationships. And so the way in which we've done that is to really build those relationships with individuals in the community so that we can do what we call warm handoffs. So we invite individuals from the community to bring their clients to us, whether it's CPS or other child welfare services or other programs, whether they're the referral source or a community program that's providing services as well. We encourage them to work with us, and we welcome them into our system. We have even asked for permitted access to child welfare services to actually have a member of child welfare on our interdisciplinary team. So we try to create an environment where we are an open system. So the next is about our organization, which is really our team. And we very much want to create a culture of customer satisfaction and empathy. We have created an environment where we are oftentimes asking our clients if they need anything else, what else we can do for them, if we met their needs. So continuously eliciting feedback on whether or not what we're doing for them is useful. Our interdisciplinary teams themselves, I feel like, are a big part of what makes us successful. We have weekly team meetings, same time, same place, every single week. We are encouraged to, and these are with the physicians, the nurse, the social workers, the entire team is present at these meetings. And the goal is to really put on the table the clients that we are having difficulty with or that are having difficulty in general, so that we can brainstorm solutions. So even though there are many professionals at different levels at the table, including the physician, we try to create a non-hierarchical system where the focus isn't on promoting what a great job we're doing, but rather talking about the challenges. Also we have included peers in that model, which has been incredibly important in terms of integrating for those clients that are difficult to reach and integrating different perspectives. So we have a peer navigator that we integrate into our team. The next is that we've defined benchmarks around retention. So I think it's important, if you're thinking about how do we measure this, for you to just create measurements around what it would mean, what would be successful in terms of a period of engagement. For us, it's the time of diagnosis to engagement, and then also what it would mean for retention. So for us, there must be 2 visits within an annual time frame that would where the individual is engaged in medical care. So for us, it's a very broad definition, but I think it's important to have markers depending on the environment that you're in. Those are the national definitions, by the way, for HIV. And the last is within our organization is we really promote employee self-care. We acknowledge that vicarious traumatization is real, and so we create environments where prior to our interdisciplinary team meetings, we are able to do some guided meditation or some self-care, recognizing that it will deepen the conversation that occurs around the clients. So in the next slide, you can see a visualization of what that looks like, where we have the mother or the family at the center of our team, and then we have the substance abuse counselor, physician, case managers and peers, psychiatrists, mental health professionals, and our OB nurse and pediatric nurses. So I think from a staff level, we really encourage family involvement, social support involvement. We are thoughtful about encouraging clients to bring whoever is in their family or their friends to their visits with them to really enhance their social network. We believe deeply that the model itself is useful in getting an increased level of personal contact. So between the case manager and the mental health counselor, that our clients are having a lot of relationships with different providers, and our team meetings are useful in terms of downloading the information and really processing as a group. But we encourage many relationships with different providers on our team. We acknowledge that without the resources, it's impossible to get to us, and so we have worked really hard to allocate resources for cell phones. We actually give a cell phone for families a disposable cell phone where families can use to communicate with us. We provide funding for transportation. We do more and more home visits when we know that it's going to be difficult for families to get to us. And we use motivational interviewing as a core of everything that we do, where we're not looking to persuade people or coerce them into making decisions that improve their life. We're really encouraging them to decline should they so choose, and looking at really where they want to change and looking at it from their perspective and negotiating a plan. So I created a checklist of things that if you were analyzing your program, things that you'd want to look for, the strong community relationships and how you actualize that, the individual relationships, how you do your handoffs between your referral sources, the community service providers, how you encourage them to join your interdisciplinary team, how you create a culture of customer satisfaction and empathy. Do you have interdisciplinary teams? Do they have a place where they could actually have meaningful conversation? How is that facilitated? How do you measure retention? How do you promote employee self-care? How do you incorporate psychoeducation and systems navigation into those? Because many of us are in large medical and social service agencies where that's even difficult to do. How do you encourage social support or family involvement? How do you create a culture where you explain to the client that they're going to have relationships with many of your team members and that the stuff that's talked about gets communicated among your team to enhance those relationships? And how do you provide resources for communication and the transportation? And then do you use MI as a core technique that's used in all of your evidence-based interventions? So that is the end of the presentation. I think we're going to open it up for questions and comments.
You'll notice that on our end, all of your lines are unmuted. So if you've muted your line, please feel free to unmute it at this point. And both Tina and Jennifer are available for questions. I'm actually going to kick it off while we're waiting for folks. Tina, something that I know folks are struggling with and that I've often wondered is, you mentioned that staying individualized and culturally focused is very important to engaging and retaining clients, which makes sense on face value. I'm wondering how you're able to do that in the face of evidence-based practice, when there's, kind of a prescriptive formula for how to engage with families and what you're supposed to do at each visit, and I know that can be off-putting to clients, and I'm wondering how you keep your program individualized and culturally focused.
Well, our model is actually an evidence-based practice. So we're on the California Clearinghouse, and we're actually training, we're actually in 2 other states right now training folks on how to do our model. And essentially that's the core of our evidence-based practice is individualizing and staying focused with families on where they're at, which so we don't have, the staff are in the Project Connect model, essentially we're involved a minimum of 2 times a week in the home. And if they're not actually in a home, then we go to where they're at. That could be the prison, that could be homeless shelter, that could be meeting them at Dunkin' Donuts on the corner because they are physically homeless and don't have a place. So we'll meet them out in the community. Rhode Island's a very small state, so we're statewide, so we'll travel anywhere in the state. I know when I presented that at a different conference, people in Texas kind of lost their minds when I said we were statewide. But Rhode Island is tiny. We're 52 miles one way. It's about an hour one way and about 45 minutes the width. So we're able to move around fairly well and get to people. So I would say as far as accessibility, being home-based and the amount of time that we can be in the homes, you get to know folks very well. So we do use we use the nurturing program for families in substance abuse who are substance affected. And I will say that we stay very closely to that evidence-based practice for our groups, but that's done within our model itself. Did that answer your question?
It does. I mean, essentially, it sounds like you have created a model that is individualized and culturally focused.
Absolutely. And culturally focused, as I said, I can't emphasize strongly enough. In our area, we have a very diverse population, particularly in our capital city of Providence. And so we really are conscientious about hiring from the populations that we are serving. And gender, age, we take a lot of things into account when we're hiring. And I can't emphasize that enough, that that's been a very successful practice of ours.
Makes sense. Thank you. Does anybody else have any questions or comments for Jennifer or Tina at this point? You know, something that I'm curious about, I'm going to ask this of both of you. If you both mentioned several things that your program does that increases engagement and retention. If you had to isolate one discrete effort that could be replicated by other programs that you think most benefits retention, what would you say that would be? If a program could just do one thing.
This is Jennifer. You know, I think it's a great question, Amanda, and because I certainly I presented on a multidimensional sort of considerations that need to be addressed, but I feel like, in other places that I've worked, probably like many of the listeners, the no-show, no-call rate is about 50%. Mm-hmm. And I see differences in the program where I'm working now, and I believe that the difference is related to, in large part, to the interdisciplinary team. And I know there's a lot of discussion about the medical home model and the one-stop shop, and I know that it's very, very difficult to implement for so many reasons, time and it's non-reimbursable in terms of the hours that are spent in that meeting. But I have found that the result of the interdisciplinary team has resulted in the client sort of feeling like there is a group of individuals who are caring for them. Mm-hmm. And so it's not just one relationship or one individual, but a sort of probably a little dramatic, but a family of individuals that really care for the person. And so I think it's good for the client, and I also think that it's really good for the team because our clients are so high risk, that nobody ends up feeling alone with the challenges, whether it's the successes or the failures for that day.
I'll also echo what Jennifer is saying, which is team approach. Staff talk about it, clients talk about it. And then I would also say, as kind of my backup, which would be helping families really meet their concrete needs. Figuring out those logistics, but also we have an emergency assistance fund. We work with families pretty vigorously on getting their financial and employment, educational needs, all of those kind of Maslow's hierarchy base foundational needs met to some degree or another. I can't emphasize that enough.
Thank you. We'll give folks one more opportunity before we close the call for any last questions or comments.
Jennifer, would you talk a little more about the role of the peer navigator?
Sure. It's such an interesting position. It's one that's very much supported in the HIV community, so it's pretty known to the HIV world. But as having sort of supervised those individuals, there are a lot of challenges associated with working with somebody from the community, asking them to pretty much self-identify as being an HIV-positive woman or parent, in many cases with an HIV-positive child. So they have to be willing to sort of be out in their community And they need a lot of supervision in terms of being able to recognize how to be helpful without becoming a friend. But what we found is when we're able to provide that level of supervision and really incorporate that the peer into the team, so they feel like it's okay to ask a question of, this person wants me to meet them for coffee at their house, is that okay or is that not okay, to really explore the boundaries, that the access that they have is tremendous and very different in many cases from high-risk individuals that the professionals maybe couldn't connect with or couldn't access. And so we found it that we oftentimes will call in the navigator, so to speak, when we are not being successful, and we've found great success.
Thank you. Thank you.
Sure.
Well, if when we get off this call, a pertinent question or comment comes to mind, then you'll have the opportunity to ask it in our online forum. So you'll be receiving an email in the next day or so asking you to create a login for the online forum. And there we'll start some prompts about how you are promoting engagement and retention in your project, so we can start some discussion about other ways that that's happening in AIA projects. But you'll also be able to ask any follow-up questions to both Jennifer and Tina. So I encourage you, when you see that email come through asking you to join our AIA group site, that you go ahead and create a profile so you can continue the discussion. And I just want to thank everybody who was on the call today. These have been really interesting and wonderful to get to know more about the AIA project, and I look forward to more in the future. Have a wonderful day, everybody, and thank you so much, Jennifer and Tina, for being with us.
My pleasure. Thank you.
Take care.